Hi, welcome to the third video in my psychiatry channel, and we're continuing our conversation about anxiety. This time we're going to be talking about treatments, and again, it's complicated stuff, but I wanted to kind of simplify and kind of like structure our conversation so that you have a good idea of, how most psychiatrists and mental health professionals go about treating anxiety. So there are two broad interventions, as we call it, for anxiety. One is psychotherapeutic, and the other one is medications. So let's talk about medications, because I'm a practicing doctor, and I guess you're very interested in that aspect of what I do. So there are an array of medications available for anxiety, but broadly speaking, there's the long-term treatment of anxiety with medications such as the SSRIs, selective serotonin reuptake inhibitors, and they include things like Paxil, Prozac, Zoloft, Celexa, Lexapro. You've probably heard of a lot of these and seen them on TV. These have been the mainstay medications for anxiety for decades, actually, and their effectiveness is established. And I've seen countless people recover from those very disabling symptoms of anxiety, such as over-ruminations and intense panic, etc., from just consistent and proper treatment of their disorder with an SSRI. Now, in some of the blogs I've written, I talk about the kind of principles by which I prescribe, and this is where I think out there in the field it's a bit hit and miss. So what we are taught in medical school is when we're treating something, we want to be able to treat it adequately, and the yardsticks that we use, and I don't want to bombard you with terms here, but essentially you want the right dose of the right medication for an adequate amount of time. And I am surprised at when I inherit certain patients, it's been a hodgepodge of medication treatments that have been inadequately dosed for inadequate time, sometimes the wrong medication altogether, and there's no real science to it, when in fact there is a science to it, and it's just been improperly applied depending on where they've got their treatment and the inclination of the practitioner. What I'm a very big proponent for is principled prescribing. And what that means is I'm going to do it properly, even if the patient may not see that at the outset, but I'll be educating them along the way to say, look, this is what I know works. It may not work as fast as you want it to. It may not work as well as you want it to in the beginning, but I do promise that we're going to keep on this journey until we find something that does. And I guess because of their faith in my confidence in this approach, they kind of work with it, even though they don't know quite where we're going with it, and eventually find out within a few weeks, actually things are working, things are better. Now, it's not a flip of a switch, so the ruminations will get slightly less often. So I use intensity and frequency as my yardstick for how is the medication working? And adequacy of dose matters. So, I know the dose ranges for various medications. I'm not going to go into detail with them here, but suffice it to say, they've got to be properly dosed. Why? Because underpinning all these SSRI medications is the principle that low serotonin is associated with many of the symptoms of anxiety and mood disorders and their manifestations. Irritability, physical symptoms, panic attacks. And when we bump up the serotonin effectively over time, which the receptors have to adapt to that increase in it by the SSRIs, we effectively are treating it downstream, and it doesn't kind of manifest in those bumpy rides, roller coaster symptoms that the patients have come to me in the first place with. So I'm going to give you a little potted example of how they work. Essentially, think about the transition between two neurons, how two neurons talk to each other as these chemicals going across, these bubbles bursting, releasing their chemicals which hit the receptors on the other side. That's how neurons talk to each other. And then think of it as a recycling bit, as whereby the chemicals then retaken up back into the original neuron. Right? The neuron that was first talking to the other one. Well, what happens is that the SSRIs block that part. What happens as a result? You get a build up of that same chemical because it's got nowhere else to go, and it keeps on bombarding more of the receptors on the other neuron, and that is what increases the kind of level of torque between the neurons. So if we want to increase the level of serotonin torque, and again I'm simplifying this vastly, but I'm trying to essentially convey that we're increasing serotonin neurotransmission because we know it's associated with improvement in these disorders. Lo and behold, clinically it pans out in practice. So this requires a kind of understanding of the mechanisms of how they work, and also understanding that the reason why it takes time for them to work is because there's a concept called downregulation. When the receptors get constantly bombarded, at the beginning they don't know what's going on, and oftentimes with an acute surge of serotonin they could get, maybe a side effect such as a bit of loose stool or a bit of a mild headache, and that happens at the beginning sometimes. Not every patient, and depends on the dose, it depends on the patient. But the downstream therapeutic effect is supposedly related to what we call down regulation. The receptors kind of get used to it and there's less of them around. But it's a bit like a thermostat. When you increase the heating, it's going to kick in later. So I use that analogy with my patients because that gives them a realistic time expectations, because anxious patients are typically not very patient about their anxiety because it's simply so disturbing. But if they're reassured that this is kicking in day by day, it's wearing in, it's not wearing off, then they will be able to have realistic timeframes, and that way they're not going to add to their anxiety in anticipation of it working. Oh, it's not working. You can imagine an anxious patient thinking, it's not working, I'm going to go back to the doctor, nothing's going to work, and they're going to be overwhelmed with this whole train of anxious thoughts which keep the anxiety perpetuating. So that's how the SSRIs work. Now, there are other medications we use as needed. I mean, simply speaking, if you're having a panic attack, a Prozac is not going to help you in the middle of a panic attack if you just pop it. It should never be used that way. It is not used that way. What we do use are two sets of medications that can reduce what we call the arousal, the kind of hyperness that occurs in an acute panic attack or severe anxiety to the body, which is really discomforting. One of these is the benzodiazepines, and there are various different types. Your Xanax, your Ativan, your Klonopin. Now, these have gotten a bad rap over the years, and even I don't favor them because they're kind of addictive. And what they do is they kind of attach themselves to what we call the benzodiazepine receptor, which provides immediate relief of the arousal. That sounds great. The problem is then you've beholden yourself to something else, and you're not really treating the disorder, and you're more likely to become psychologically as well as physically addicted. And it happens. I've seen inherited patients who've been on these things for years, and it's really hard to come off them, and you can get unintended consequences such as seizures and withdrawal symptoms, which are really uncomfortable and even potentially fatal, depending on how long they've been on them. So my approach is to kind of steer clear of those and to use alternatives which are non-addictive, such as hydroxyzine, also known as Vistaril or Benadryl, which are antihistamines that do an equally effective job if they're adequately dosed, but they're not addictive. What they are supposed to do is not eliminate the anxiety. I'll repeat that. These medications are not supposed to eliminate anxiety. They're supposed to reduce it to the extent that you can use what we call your own coping skills. And this is the second half of anxiety. One of the things I've realized with patients who are anxious is oftentimes, unconsciously, they perpetuate their own anxiety. And it's become kind of a hardwired habit for them, and it's not their fault. They don't realize that they can get in their own way of their own recovery with such approaches. So, for example, if you notice that when people are in a panic attack, they're worried about dying, and then they get certain symptoms and they think that that means that they are dying, and you can see the cascade, how that kind of escalates into, even worse symptoms. So they're misinterpreting symptoms that then cause worse symptoms that they misinterpret, and it becomes a very bad cycle that has to be broken. These are called catastrophic thoughts, jump to conclusions thinking. And we've got to be able to deconstruct that thinking in between panic episodes so that if and when it comes, the patient doesn't buy into it, doesn't feed it, and thereby escalate themselves. So those coping skills are supposed to be used pretty much all the time, because there'll be upticks and downticks of anxiety. You can't predict when one will be more severe than the other. So what we do is, if something is unusually severe or it's very difficult to tolerate, we do recommend that they use an as-needed medication, but to couple that with their own efforts in terms of what they've learned in therapy of how to cope, how to de-escalate themselves. I call them self-soothing skills. Others call them coping skills. But it can be simple as deep breathing, meditation. And in the beginning, it can be a hard sell for the patient because they don't have the buy-in. It doesn't work. They haven't practiced it. And I often say, practice makes perfect, and we're going to have to change some circuits here. But if we do this together with the medication, you'd be amazed at how powerful the results are. It's hard. I oftentimes have to metaphorically hold my patient's hand during that process to help them become more empowered rather than being so overwhelmed by their anxiety, which they think is coming from outside them, but actually there's a part of them that may be feeding it without them realizing it. So this is a subtle conversation. It's an educative process. It's an attitudinal shift towards their anxiety when they know it's not dangerous and they know that they can do something about it. That the two combinations are extremely powerful. So that's a little summary of how they work together. So there are different therapies for anxiety. We can talk about these in subsequent videos. But essentially, there are lots of different theories as to what causes anxiety, and some of the theories are tailored around that. So there's here and now therapies, and then there's therapies that go back to, their childhood. So I don't want to discuss that in this video, but I wanted to give you a taster of how we broadly approach this. And again, I hope this is helpful, and we will discuss in the subsequent videos in more detail about other ways and means by which anxiety is tackled. As always, I want to say thank you for your support of this channel and stay healthy. Thank you very much.